Well, good morning, everyone. Happy New Year. Welcome to 2025. For some reason, I have not been having a hard time writing 25, which I usually do every New Year. So maybe that means it's going to be a good year for all of us. Um, but I'll get to things. I think Lucas let us off last year also. So this
Mhm.
is just now going to be a regular thing, obviously. I'm just kidding. Only if you want to. Um, a man that needs no introduction, but Dr. Lucas Hill leads the clinical pharmacy team at the Owen Clinic. He completed his PharmD at the University of Southern California and residency at UCSD in 2012. And he came specifically to UCSD to work and train with Craig Ballard at the Owen Clinic, um, who I was just watching on a a video that apparently was recorded in 2015. It was really nice to see him again. Uh, After residency, Lucas led the clinical pharmacy services for hepatitis C monoinfection clinics at UCSD, and then helped with the HIV Hep C co-infection clinic until 2017 when he joined and now leads the pharmacy team at Owen Clinic. And he's going to be talking about resistance testing today, and very excited about this. So I will turn it over to you, Lucas. You know, I got your the box for
Mhm.
you.
Questions? Yeah.
Yeah, questions.
Yeah, cool. Thanks, Jill. Morning, everybody, and Happy New Year. Yeah, like Jill said, I'm excited to be able to get the first high rounds of 2025, and I do think it's becoming a holiday tradition now. So this is the second or third year in a row that I've done the first one of the year. So very excited to talk about some questions around HIV resistance testing. And so, yeah, I think the last few years I've done talks mostly around injectables, and I thought about doing it again this year with some new data we had, but kind of decided to shift gears and there's various questions that continue to still come up in the clinic or when I talk with other providers about resistance testing. So I thought it'd be nice to review some of the data that's available. And it was kind of nice to put together a talk that I haven't given before. I got to do a lot of research of my own and learn a few things. So that was nice. But I know since the group is kind of mixed in terms of some being providers and some not. I'm just going to try and give just a brief overview about HIV resistance testing and kind of how we go about deciding on the appropriate tests, and then kind of just kind of cover three different questions. One is around baseline resistance testing. The other is just about proviral DNA resistance testing in general, which would be the bulk of it. And then last, about how we manage resistance testing in people on long-acting injectables who might disappear for a while. So just to start, this is kind of an overlay of the dates of different HIV resistance tests when they became available, along with the antiretroviral drugs that have been approved. And this comes straight from Monogram's website. So, Monogram is not obviously the only place to order resistance testing, but they've been involved in resistance testing in HIV for essentially ever since it's existed. And so, um, a lot of the information comes from Monogram, but as you can see, there was resistance to antiretrovirals documented and published as early as the late 80s, early 90s, not too long after the first antiretrovirals were approved. And then I think, around 99, 2000 is when really we had, commercialized HIV resistance tests become available, and it became a much more frequent thing that was ordered. After the 99 2000 time frame, we had integrase added, which was a big step in 2012 with GenoSure Prime. And then I think the most recent kind of biggest change was the availability of proviral DNA resistance testing, or GenoSure Archive, in 2014. So when thinking about kind of the steps for deciding on types of resistance tests that we can order and what's available, I kind of created the simple diagram on the right for about kind of how I think about it. So, if you identify a patient who needs resistance testing, kind of the first decision point is what are you going to sequence? And so you can either choose to sequence viral RNA, or you can sequence proviral DNA. And the figure on the left kind of outlines the differences between the two. So, with viral RNA, essentially what you're doing is, so you have to have a detectable viral load to be able to sequence viral RNA. So there has to be circulating RNA, and you isolate that from the plasma and sequence that for your resistance test, versus proviral DNA is typically used when people do not have a detectable viral load, most commonly because they're on antiretroviral therapy. And you are extracting peripheral blood cells from whole blood and sequencing the integrated proviral DNA that is in the peripheral blood cells, and then generating resistance information that way. So after you kind of make that determination of what you're going to sequence, if you're going the viral RNA route, typically there's a decision of choosing to include integrase or not in the resistance test. So, pretty much all resistance tests will come with sequencing of reverse transcriptase and protease. But the integrase can be chosen to be added or not. It does add cost, and it would be determined if the patient is receiving an integrase inhibitor, and you want to look for integrase resistance. And then the kind of final decision point would be, do you want to do genotyping or phenotyping? So genotype is where you're just going to get a list of the mutations that the patient's virus has, versus phenotyping, which is kind of reported out in this way, which is growing the patient's virus and exposing it to the various antiretrovirals. And what they're measuring is the IC50, which is the amount of drug required to inhibit 50% of viral replication. So you see, for example, the blue line, it would be this point here would be the amount of drug it takes to inhibit 50% replication in a wild type virus with no resistance. And then you have the resistant virus, where it takes more drug to inhibit viral replication because of resistance mutations. And what you're getting reported is the fold change in the IC50. So that's kind of the idea behind phenotyping. So, going back to the comparison of RNA versus proviral DNA resistance testing. So, an RNA resistance test, they're typically like brand names for Monogram would be GenoSure MG or GenoSure Prime, which would include integrase. And typically you need a viral load of greater than 500 copies to do an RNA resistance test. And it's important to understand when interpreting those tests that they're influenced by the drug pressure that's present at the time of the test. So, for example, if someone's not taking an NNRTI, then NNRTI resistance might not be expressed in the RNA resistance test, because what you're sequencing is the predominant circulating virus populations at the time, and that's influenced by what medications the patients are taking. We'll talk about sequencing and Sanger versus next-gen sequencing in a second, but typically RNA resistance testing is using Sanger sequencing. So when you're thinking about these resistance tests, there is a cutoff that the tests will report out in terms of drug resistance mutations as a percentage of the total viral population. So so typical Sanger sequencing and RNA resistance test is going to report 10 to 20%. So if a resistance mutation is present at that level of 10 to 20% of the total viral population, then it'll be reported on the resistance test. And if it's less than that, then it won't. And I would argue that, RNA resistance testing is the clinical impact is well validated over time. In comparison to proviral DNA resistance testing, which is typically referred to as archive genotype. So this is, designed typically to be done when for suppression management, when viral loads are less than 500, although we'll talk about its use even in the setting of viremia. But it's given the nature of the test and how it's done, it's not influenced by drug pressure that what regimen the patient's taking at the time. And typically proviral DNA resistance testing is using next generation sequencing. And so That means that you're getting reports out of resistance mutations at lower frequencies of the viral population than 10% typically, or 20% for Sanger sequencing. Um, and then, as you'll see, I think the part of the no, I don't want to say controversy, but questions is that the clinical impact of proviral DNA resistance testing is not as well validated. So just finally to touch on Sanger versus next generation sequencing, I'm not a bench scientist, so I'm not an expert in these different sequencing methods. But the point is it's important to understand when you're evaluating resistance tests about what is being used and what percent of the viral population is being reported. And so like I mentioned, Sanger sequencing typically is going to report around 20% of the viral population if there's a resistance mutation present. The strengths they report here is that, there's several validated methods, there's low sequencing error, it's relatively simple workflow. Versus next-gen sequencing, which is often used now for proviral DNA resistance testing, allows for higher throughput because it allows for pooling of more samples. And it also allows for the detection of much lower abundance drug-resistant variants. So, down to 1, 2, 3% of the viral population will be reported. It is more, I guess, complicated and requires probably more specialized um, uh, uh, processes, but it's important just to keep in mind the difference between these two types of sequencing. Okay, so let's get to the first question around baseline resistance testing. Baseline resistance testing has obviously kind of become the norm for anyone that's newly diagnosed with HIV. And this is kind of the recommendations from the DHHS guidelines, which is resistance testing is recommended in anyone that has acute and recent, but also chronic HIV infection to evaluate for transmitted drug resistance. Um, and they also recommend to consider repeat resistance testing if someone delays ART initiation after their initial test. If you're concerned about possible superinfection, which would be a kind of a reinfection with drug-resistant virus. Um, and in terms of what type of test to choose, genotype testing is preferred over phenotype due to lower cost, faster turnaround time, and greater sensitivity of detecting mixtures of wild type and resistant virus. It's recommended to sequence reverse transcriptase and protease for everybody. It is not recommended to include integrase resistance testing in baseline resistance testing because the frequency of transmitted integrase resistance is quite low and has been low for a while. They would recommend adding, integrase testing if you have a concern for integrase resistance, right? So, for example, maybe someone that received cabotegravir for PrEP. Fortunately, given the medications that we, currently use for people who are treatment naive, being, medications with high genetic barrier to resistance, you don't have to wait for the results before you initiate ART typically, but still are supposed to get the resistance test. So this is obviously part of the reason why baseline resistance testing is recommended. This is data through 2018, but looking at frequency of transmitted drug resistance in the United States, and so total prevalence of any resistance is up close to 20%. NNRTIs are the most common class where you see transmitted drug resistance around 12% or so. And then at the bottom would be integrase, which kind of seems to hover around 1%. And then on the right just kind of shows some of the frequency of maybe what you would consider more significant drug resistance mutations that could have effect on regimens, and maybe potentially regimens we use now. But even the one that's at the highest prevalence, M184V, is still quite low at less than 1%. And then the others have a quite low prevalence of transmitted drug resistance. So, it's interesting if you kind of look at the guidelines and the reference they cite for the need for baseline resistance testing. This is a paper from 2005. titled "Should Resistance Testing Be Performed for Treatment-Naive HIV-Infected Patients? A Cost-Effectiveness Analysis." And obviously, we've had change in language over time. The point is that, this is a cost effectiveness analysis about baseline resistance testing in the era of antiretrovirals that we used in 2005. And so, when they did this analysis, they used an assumption that, 75% of people would be starting in a efavirenz-based regimen, and then the other 25% lopinavir-ritonavir-based regimen. And they kind of, looked at or determined, suppression rates at 48 weeks, which is that table on the left, by different regimens. So essentially, it was like they started in a efavirenz-based regimen, and then they could go to two PI-based regimens, and then it was salvage regimens after that. Um, and so, um, uh, using that data from different studies at the time, they determined what, would be the cost effectiveness per quality of or cost per for quality adjusted life year by doing baseline resistance testing. And they use different costs of the test, but $400 is about reasonable for a base, just a reverse transcriptase protease RNA resistance test. And they use this as their reference, which is around 8.3% of the prevalence of resistance. And essentially, it was determined all the way up till, down to a prevalence of 1% resistance, that this would be cost effective at less than $50,000 per quality. This paper, though, was from 2020, and I remember reading it a couple of years ago, and it's kind of stuck with me. This basically did the same thing, which was a cost effectiveness analysis. Even some of the authors are the same from that paper in 2005. But instead, looking at cost effectiveness of doing this in the more using our current antiretroviral. So in this, case, they assumed that everyone started two NRTIs plus a second generation integrase. And really, in that previous paper, what was, driving regimen changes was virologic failure for the most part, particularly in the situation of transmitted NNRTI resistance in someone that would have started a baseline, an NNRTI-based regimen as their first regimen. In this paper, really what's driving changes in antiretroviral regimens is just side effects. If patients develop side effects, to the integrase inhibitor-based regimen, but not really virologic failure, because we see much lower rates with second-gen integrase regimens. And so, if someone did go to an NNRTI, it was rilpivirine-based, or PI, it was darunavir-based. But really, what this paper determined is that baseline resistance testing probably is not cost-effective. There was very little change in the quality adjusted life years, and they determined a cost effectiveness ratio of $420,000 per quality. So their conclusion was that baseline resistance testing is only cost effective unless there would be a scenario where dolutegravir-based regimen has less than 50% efficacy with transmitted resistance, which is obviously not going to be the case. So I just thought it was interesting. Someone the other day asked me if we still do baseline resistance testing, which we definitely do. The guidelines recommend it. So we do still do baseline resistance testing for everyone, and I'm not saying that we shouldn't. I'm just saying I think it's an interesting question that probably needs updating in given the current regimens that we use, because I think thinking about all the baseline resistance tests that we've done, since second-gen integrases have become first line. I don't think I can think of a scenario where we had a result on a baseline resistance test that changed that initial regimen. So, just thinking about kind of advantages, disadvantages of doing baseline resistance testing, advantages still is that, that paper from 2020 did not take into account the use of two drug regimens for initial treatment. So, I think this is really based on your standard two NRTIs plus a second generation INSTI, and not necessarily to, our two drug regimen that we start in people who are treatment naive. So that's one thing to consider. I think there is still valuable information that can come from baseline resistance testing. So for example, looking for transmitted NNRTI resistance in someone who you're evaluating for switching to long-acting cabotegravir, rilpivirine, that might be valuable. The question is, do you need to do that with baseline testing or just, now that we have the availability of proviral DNA resistance testing, would you just do that in a situation where you needed it? Or, for example, someone that wanted to switch to an NNRTI because of side effects. So that being said, there is greater cost of proviral DNA resistance testing versus a standard genotype at baseline. Disadvantages, I think that paper demonstrates it's likely no longer cost effective in the current era of second-gen INSTI-based regimens. And I think, given the regimens that we use, there probably is limited clinical impact, even when someone has transmitted resistance. I think data continues to accumulate that even with NRTI resistance, our second-gen INSTI regimens are going to be highly successful. And I think there could be an argument for surveillance data with baseline resistance testing. The question is that the appropriate use of healthcare dollars, particularly from insurance companies and people's insurance? If that's the only reason we're doing it, then maybe that should be funded from a different mechanism. But this is money being spent that could be spent elsewhere. So it's just food for thought. Again, I'm not suggesting we should stop doing baseline resistance testing, but I think it's an interesting question. So I can pause there, Jill, before I move on and see if there's any comments or questions.
Yeah, I mean, I think what Nettie brought up in the chat, I think this comes up a lot with related to the switch to Cabenuva. I don't know, Nettie, if you want to say it, I can just read it if that's easier.
No,
But
I think we were
go
just
ahead.
saying
Yep.
how we use it. Like I definitely go back to that test fairly regularly every time someone's going to a rilpivirine regimen. There's a decent amount of transmitted rilpivirine resistance, and it's not an ignorable resistance mutation to have. So I think it's pretty important. I was also about to add in the chat that it's also a precious piece of information that can't be obtained later. And so whether or not it's a good use of insurance dollars, it's not that expensive a test, but I can't go back and get your baseline test ever again. And so I do think there's an argument for keeping it around for that reason. Yeah.
Yeah, both of those are good comments, and I think, yeah, both something to think about as them still being having useful situations.
That's all, Lucas. You can go
Okay,
ahead.
great. All right, so next, the bulk of what I want to talk about is proviral DNA resistance testing. I think that, it's been around for 10 years now, and I think there's still a lot of people have different opinions about how, if they do or do not use proviral DNA resistance testing. Um, and I've talked to some clinics where they don't do it at all. Our clinic, for example, does a lot of it. And so just thought it would be good to review the data. Again, I don't know if this provides answers necessarily, but just information about what data is available. So just thinking about it from a clinical case perspective, just as an example, this is a patient who's a 65-year-old male with a history of treatment since the early 90s, who came recently for regimen simplification. So he had come to us on a regimen of fostemsavir 600 milligrams twice a day, doravirine 100 milligrams daily, and boosted darunavir. 4 pills a day, twice daily dosing with fostemsavir. And so his treatment history is pretty much completely unknown. We know that he's been on many different regimens going back to zidovudine. And so the only piece of resistance information we had was this GeneSure Prime done a few years ago. That at the time he was taking fostemsavir with boosted darunavir, base regimen. And sorry for the bad quality. It was a scanned in fax, but what you can see is kind of what would be expected for someone with his treatment history, right? So he has a lot of NRTI resistance, and he has some PI mutations. But what didn't show up on the resistance test was there's no NNRTI resistance and no integrase resistance. I think that if you looked at this for face value, you might count on, the NNRTIs to be a significant contributor to his regimen. But what's important, obviously, to kind of remember is that he's not on an NNRTI at the time that this resistance test was done. And so we talked about the influence of drug pressure. And so We did get an archive genotype, proviral DNA resistance test in him. So it still, detected all of the NRTI resistance and as well as the protease mutations. But what did show up on the resistance test was significant NNRTI resistance mutations. Um, I think, two things. One is this kind of maybe demonstrates some of the value of proviral DNA resistance testing is that, this is going to impact your decision when you kind of simplify his regimen. But I think what's, still a question is, how clinically significant are these mutations that are detected on proviral DNA resistance testing? But that's still not totally understood. And then the other value is that, although if it doesn't show up on our archive genotype, doesn't mean it's not there, but also the confirmation of no integrase resistance. So, I think this is a example of where, this is valuable information when you're thinking about making regimen changes. Um, on the flip side, I think everyone that's done proviral DNA resistance testing has seen similar situations like this, where these are two resistance tests from the same patient, right? One, this is a PhenoGT from 2005, and you can see what it detected was several NRTI mutations, some TAMs and a 184V, but also a significant NNRTI mutation. And then we did a proviral DNA resistance test in 2018. And some of these significant mutations did not show up on this resistance test. And so if you didn't have this information and this was what you were making decisions on, that could have an impact on your decision. And so, I think this is the scenario that comes up where people are, somewhat questioning the clinical utility of a proviral DNA resistance test. But at the same time, I think there's also questions around if it doesn't show up on here, does that actually mean something or not? And that's still a question that's not totally answered. So I think also just wanted to kind of mention, we talked about already people evaluating people for long-acting, cabotegravir rilpivirine. And this is the post hoc analysis of the large phase 3 studies looking at what were the significant predictors of virologic failure. On injectable rilpivirine, and the biggest predictor was having baseline rilpivirine resistance. And as Nettie mentioned, you certainly can see transmitted resistance mutations or even polymorphisms that can affect rilpivirine. And then, we know that NNRTI, resistance can be somewhat common in people that have taken NNRTIs. And so, if you're interested, these are the resistance mutations that were included for rilpivirine in the analysis. But the point is, based off of that data, it does raise questions about, how do you use proviral DNA resistance testing and evaluating people for cabotegravir or rilpivirine? We've kind of taken the approach of if we don't have prior resistance testing, either baseline or a prior RNA resistance test, we generally are getting proviral DNA resistance testing before we start people. And this is information we published about people that this was 135 people that had proviral DNA resistance testing as part of their workup for cabrilpivirine, and we identified 18.5% that had a resistance mutation that could have affected the activity of cabrilpivirine. And this is the list of the different mutations that were detected. But we think that's our goal is obviously no failures, right? And so we felt it's worth looking for, and we still do. But I think the question is certainly still out there because this is the data from the CARE study, right, which is the use of cabrilpivirine in Africa. Um, and what was probably a little bit different for the CARE study is that given that this takes place in Africa, there are high rates of NNRTI resistance, and that's the concern about using this regimen in that setting. 75% had previously been on an NNRTI, and 12% had rilpivirine resistance mutations at baseline. This is the list of the rilpivirine resistance mutations that were at baseline. So majority were E138. Of those, the 11 of those were E138A. which has a little bit less clear clinical impact on the regimen as some of the other mutations at that position. But the point is, despite this, they only had two virologic failures in the study on the long-acting arm, one of which had no baseline rilpivirine resistance. The other had an E138A. I think this study is brought up the question of, one, surprisingly, why did it do so well in a situation where there was a good amount of rilpivirine resistance mutations, and two, what is the clinical impact of those on this regimen? So, as compared to the studies that led to the approval of the regimen. So thinking about the use of proviral DNA resistance testing, so there is good evidence that resistance mutations do persist in the proviral DNA. So, the estimates vary between what papers you look at, but, obviously not all provirus is replication competent. So it's estimated 10 to 12% of provirus is replication competent. But there is also evidence that proviral DNA can recombine and generate resistant virus regardless of the viability. And when we kind of look at, the persistence of resistance in the proviral DNA, this study from De La Cruz looked at 28 people who had failed an efavirenz-based regimen with a K103N, and then were resuppressed on a PI-based regimen for up to 10 years. And when they used Sanger sequencing of the proviral DNA, they still detected K103N in around 50% of the samples up to 10 years after they failed. What they saw was that the odds of having a detectable K103N was higher per the viral load at the time of failure. And that's something that seems to be consistent across studies, is that it seems that there's likely a certain degree of viremia required for some of the resistance mutations to be archived in the proviral DNA. They also looked at deep sequencing, and they had 50% that had a K103N at greater than 20% of the viral population, and then another 21% that had a K103 between 2 and 20% of the viral population, so total retention of 71%. They also looked at M184V as well, and they detected M184V by next-gen sequencing in 25% of people at greater than 20%, and then another 14% at 2 to 20% of the viral population. So, it's evidence that obviously mutations persist in the proviral DNA, but not all mutations are likely equal, and probably some of that is related to the impact on viral fitness or the impact on the virus's ability to replicate in the presence of these resistance mutations, right? So this is a separate study that looked at the persistence of M184V in the reservoir, and they used ultra deep sequencing up to 5 years after viral suppression after developing an M184V. And they saw that 50% had lost the M184V after 2.5 years in the proviral DNA, and they saw that at both 2 and 5% thresholds for the cutoff on the viral population. And similarly, higher viral load at the time of failure was negatively associated with clearance of the M184V. So, it may not be the same, depending on the resistance mutation we're talking about. That being said, there is evidence that this study from Armenia in 2018, showed that after doing suppressed switches, virologic rebound, the risk increased if they looked at proviral DNA resistance testing, and there was a lower susceptibility on the proviral DNA resistance testing. So it does seem that these archived resistance mutations can have an impact on maintaining suppression in certain situations. In the study, the highest probability of rebound were in those that had a combination of resistance by both RNA and DNA resistance tests. Looking at the various studies that look at concordance of proviral DNA with historical RNA resistance tests. And the majority of the data that's available is that exactly, which is comparing the two. There's very little information about the clinical impact of the proviral DNA resistance test. There's a few studies, and I'll go over those, but I kind of broke this table up into two slides. This one I kind of grouped in terms of similar results of concordance. So these are studies that compared proviral DNA resistance tests with historical RNA resistance tests, and just looked at concordance of the resistance mutations detected, right? So the first one had an overall concordance of less than 50%. The majority of mutations detected only in one compartment were in the RNA. So only 10% or 9% were detected in DNA only. The second study similarly, reported out more just number actually of resistance mutations. So they showed that there were more resistance mutations identified on historical RNA resistance as compared to proviral DNA resistance. And then the last study was a smaller study, but again showed around 40% concordance with reverse transcriptase and protease, and 50% with just protease. So and did see a higher frequency of reverse transcriptase mutations in the RNA as compared to DNA. But then there's also other studies that show higher rates of concordance. And so the top one looked specifically at K103N and people switching to rilpivirine-based mutations, and saw 100% concordance with K103N in the proviral DNA over time. The second study were patients from Honduras who were failing ART and had both RNA and DNA resistance testing done at the same time. And they saw 88% concordance between the two, although they based that off of resistance profiles, not actual mutations. And so on. And so, I think there are there's a lot of differences in terms of outcomes of these different studies. One thing I think that may potentially be driving the difference is what type of sequencing is being used. So not all of these studies report if they use next-gen sequencing or Sanger sequencing, and down to what level of the viral population. But for example, these older studies that had lower concordance, I know at least these two used Sanger sequencing. And so, part of the difference that might be, one thing that might be driving the difference between the studies is that you might have in these studies with higher rates of concordance, a detection of drug resistance mutations that are at lower frequencies. The other study I wanted to touch on that did look at concordance, but I thought was interesting, is this was a study focusing on the use of proviral DNA resistance testing in viremic patients. So this is from Monogram. But it was a retrospective review of 106 people who had both RNA and proviral DNA resistance testing ordered on the same day. Part of what they point out in the study is that they also used the commercial resistance tests available through Monogram. So these were not research-based resistance tests, but for the RNA resistance test, they use Sanger sequencing for AffinoGT plus integrase, and then for proviral DNA, they use next-gen sequencing. They had a 10% threshold for those positions that undergo ApoBec-induced changes, which I haven't mentioned yet, but we'll talk about in a second. But otherwise, it was 3% cutoff for all the other positions. And so what you can see is, the top is drug resistance mutations detected, and the bottom is resistance calls based off of the resistance test. And there was high concordance between the RNA and the DNA resistance test. And in fact, if there were mutations that were detected in only one compartment, more of those occurred in the proviral DNA. And when they look specifically at those RNA tests that had resistance, so there were 117 that had resistance on the RNA test, 86% also had all of the resistance detected in the proviral DNA. And of those, 55% had additional mutations. Only less than 14% did not have all mutations detected in the proviral DNA. And even in those situations, 44% still had additional resistance mutations in the proviral DNA. So Now, this question of using, proviral DNA resistance testing in the patients with detectable viremia, for example, people off ART, is a question that's been asked for a while. I think that, this study does support that, it does work well in some of these situations in people with detectable viremia. The other thing that they looked at was the relationship between viral load and detection of resistance in both the RNA and the DNA. And what they saw is those that had higher viral loads were more likely to have all of their mutations detected in the proviral DNA. There was no real relationship between the RNA necessarily, but I think what they commented on is that, again, this issue of you may need a certain level of viremia for mutations to be archived in the reservoir. So kind of as I mentioned, there is, a limited number of studies that try to look at the actual clinical efficacy of using proviral DNA resistance testing. These are kind of the three that I was able to find. So the first one by Ellis was in 59 people who underwent proviral DNA resistance testing and then switched their ART. 58% had one class, 34% two class, and 10% three class resistance on the proviral DNA resistance test. And they had a suppression rate of 88% at a median of about a year. And identified non-adherence and a pre-switch viral load greater than 50 is being associated with a detectable viral load over time, and also commented that pill burden was decreased with the switch. The second study by Singh, Dr. Wilkin actually was the senior author on this study, but it was a retrospective study of 140 people that had proviral DNA resistance testing, of which 80 or 79 had a regimen change. They saw a quarter with one or two class resistance and about 20% with three class resistance. And they also had a good number that had historical genotypes. So they saw high concordance, so up to 75% if you look at any class, and 53.6% for all classes. And they had a high percentage that also had resistance mutation only in the proviral DNA, so 36%. And they saw an 85% suppression rate at 3 months after the switch. And then the last study was a smaller one of 35 people on non-standard ART due to resistance, who had both an prior RNA resistance test as well as proviral DNA resistance test, and 17 underwent ART optimization. And of the 17, basically at a median follow-up of 200 days, all 17 had a viral load of less than 200. And they had a reduced pill burden from 8 to 3 per day. So, I think these are attempts to look at kind of the clinical impact. I think what we're missing from the data is a comparison of regimen changes in those that do and do not have proviral DNA resistance testing, because the question is, would you have similar suppression rates even if you didn't do the proviral DNA resistance test? And part of that gets to the idea of the regimens that we have and how efficacious they are, even in the setting of resistance. And so I think there's still that missing information about how big the clinical impact of this type of test is. So issues remaining or questions around proviral DNA resistance testing. One that does come up is the impact of APOBEC-mediated hypermutation on proviral DNA resistance testing. And we haven't gone into detail about it, but the idea is that, APOBEC is a protein that can result in G to A hypermutation outside of the traditional pathway of developing drug resistance due to, viremia in the setting of low drug concentrations. And so, you have to be cautious, especially when doing next-gen sequencing, that you're not just picking up APOBEC-induced mutations, because almost always when there's APOBEC-induced hypermutation, due to the addition of stop codons, the viral particle is non-viable. And so it doesn't produce replication-competent virus. So you can see some of the common drug resistance mutations that are affected by APOBEC activity. So M184, several NNRTI mutations and some INSTI mutations as well. It's something to be aware of. Monogram, this was from the study done by Monogram that used the commercial test. So I wasn't able to find this on their website, but assuming that this is the case, because this is what reported in the study, the way they handle APOBEC-induced G to A hypermutation is they screen for those possible variants, and then they increase the reporting threshold to 10% to minimize the impact of the APOBEC-induced hypermutation false positivity on those resistance locations. And then otherwise, if it's not a position that's frequently affected by APOBEC-induced changes, then the reporting threshold is 3%. Some other issues would be, potential incomplete sampling of the reservoir, for example, in the CNS, that may miss drug resistance mutations. I think there's still a question about the clinical impact of low frequency drug resistance mutations when next-gen sequencing is used. There is, papers that show that there's evidence that lowering the threshold from 20% definitely can increase the detection of clinically significant mutations. But as you get into the very low percentages of the viral population, there can be increased sequencing errors. Some suggestions of the study suggest a 5 to 10% cutoff might be ideal. I think there's still a lack of comparison of kind of suppression management and regimen optimization using a comparison of using and not using proviral DNA resistance testing. And then, we have to consider the impact of the highly effective, high genetic barrier regimens, even in the setting of multi-drug resistant HIV. Okay, I should have time for questions at the end, but let me just briefly finish in the last few minutes about resistance testing after long-acting injectable exposure and the lack of data that we have. So,
Assume that means you saw the time. I just was going to give you an
yeah,
Okay.
I have about 5 minutes left. So,
Okay.
this is an example of resistance that can occur. The concern is during the PK tail of the long-acting injectables. And the potential for resistance to occur if patients are lost to follow-up without any intervention. And so this was a 31-year-old with a history of AIDS who had a long history of non-adherence to oral ART, secondary to substance use disorder and unstable housing. He has a history of cryptococcal meningitis, MAC, chronic hepatitis C. And then in December of 2022, he was diagnosed with Kaposi sarcoma, and he was getting chemotherapy. And during that time, he was a little bit more engaged in the clinic. He actually was able to take his BF-TAF more consistently for a month or so. His, regimens, mostly he had not been adherent to these early regimens. He had mostly been on and off dolutegravir or bictegravir-based regimens due to the need for rifabutin at different times. And he had 2 previous resistance tests, both of which were pan-sensitive. So, the top here shows his viral loads over time. So you can see, obviously, very non-adherent to ART. And then in December of 2022, for about a month, he was able to take his ART and got his viral load down to 58 copies. These are his T cell counts over time. So anywhere between 1 and 7 CD4 counts. So very low CD4 count. So in February of 2023, after he came for several clinic visits, along with him, decision was made to try and start an injectable ARV regimen. So we started injectable cabrolpivirine, but also given, his relative incomplete suppression and very low CD4 counts, also added lenacapavir, subcutaneous every 6 months. And then after he received those first set of injections in February, unfortunately, he did not come back and was lost to follow-up for about a year until he resurfaced in January 2024 when he was hospitalized with concerns for cryptococcal meningitis and had taken no ART since that time. So it's interesting because when he was hospitalized a year later, his viral load, obviously there's still an impact of the medications that were given because his viral load had not yet returned to baseline. It was around 2,000 copies. And amazingly, his CD4 count, was 306. So obviously he had good CD4 recovery that, there was still an impact of the injectables a year later, particularly probably the lenacapavir, given its long half-life. So in terms of the resistance issue, during his hospitalization, a regular RNA resistance test was done, didn't detect any new resistance. This V106I was present already and probably not super significant for rilpivirine. But what did happen is he did develop lenacapavir resistance. So this is not commercially available, but Monogram did the lenacapavir resistance testing, and he developed a lenacapavir resistance mutation, presumably during the PK tail of the lenacapavir. And it raises questions about the impact of drug pressure on doing resistance testing in the situation of long-acting injectables. And so, the idea is this figure in which case, as people are off of ART, over time, wild type virus starts to become the predominant circulating virus, and you start to get much lower frequencies of these drug resistance virus because they don't grow as well or replicate as well. Over time, you're going to get, if you do resistance tests after a certain period of time, so the guidelines would say if it's been more than 4 weeks after oral therapy, that you may get wild type virus on the resistance test. The guidelines say for people who have received long acting injectables that you should do resistance testing at any time after. But there's not a good sense of how long after that you might start to see less mutations show up on RNA resistance testing. So in his case, ideally, we wanted to get a proviral DNA resistance test to help make decisions on what to do next. Because it had been a year since he received capropivirine, but he unfortunately was lost to follow-up again, and we weren't able to do that. And all of this kind of goes around the idea that, the elimination half-life for cabotegravir is up to 11 weeks, and for rilpivirine, 28 weeks. And so, you think 3 to 5 half-lives to eliminate the drug. It's going to take a very long time for the medications to be eliminated. But I had this example in high rounds last year, but this is kind of an example of where you can see differences after not receiving long-acting cabotegravir for a time. This was a patient who was started on long-acting cabotegravir in July of 2022 with a viral load of 44 and a CD4 count of 133. And she had received 2 injections, July and August, and then was lost to follow-up until May of the following year, when her viral load was 36,000 copies and her CD4 count was 33. And at the time, an RNA resistance test, detected a new NRTI resistance. But we also were able to do a proviral DNA resistance test, which actually detected several additional significant resistance mutations. And so fortunately, no integrase resistance, but I think it does show kind of that you are seeing differences in terms of the detection of different resistance mutations between the 2 compartments after an extended period of time of being off long-acting injectable. So in terms of resistance testing after long-acting injectables, there's really no data regarding the impact of drug pressure during the PK tail on the results of RNA resistance testing. And we really have limited experience about those who are lost to follow-up for extended periods of time outside of a clinical trial setting where people were able to get resistance testing sooner after failure. And I think it's probably appropriate to consider doing both RNA and DNA, or at least adding DNA resistance testing when evaluating people who have been lost to follow-up for a period of time. So in conclusion, the impact of baseline resistance testing is likely reduced given modern high barrier ART regimens. However, there's probably still some benefits of completing baseline resistance testing. Data regarding the concordance of proviral DNA resisting with historical RNA resistance testing is mixed. And it's difficult to obtain the clinical impact of proviral DNA resistance testing. However, it's likely it does provide valuable information in certain clinical situations. But what plays into that is the impact of the highly effective high genetic barrier to resistance regimens we have. There hasn't really been any cost effectiveness studies of proviral DNA resistance testing. And there's still some questions about using it to evaluate for candidacy of long-acting cabotegravir. And then finally, optimal approaches to resistance testing in those lost to follow-up after receiving long-acting injectable antiretrovirals is still a bit unknown, and we're still kind of sorting through some of those questions. So with that, I'll stop there, and happy to take any questions in the last few minutes.
Thanks so much, Lucas. I'm going to start with Tom's comment there, and I'm sorry if I missed it too. The Cabenuva study in sub-Saharan Africa and their retrospective proviral DNA testing. Did you talk about that?
So all of the rilpivirine, so all of the mutations that were reported at baseline were through, I thought it was all through proviral DNA resistance testing. That was not done to make the decisions about switching people to rilpivirine, but I believe they did proviral DNA resistance testing on everybody before they switched.
You did go over it. I'm
I
sorry.
think
That's
they
oh, go ahead.
because I think they made the switch for everyone because it was
Yeah,
supposed to be a realistic thing.
exactly.
They archived the samples and they went back and sequenced them at the end of the study.
Right.
So they had like suppression of 98%, yet something like 20% of the cohort had resistance detected on the proviral DNA when they went back. So it was just like really striking to me to emphasize how many non-significant results we may get from proviral DNA testing.
Yeah, and if you want to compare the cohorts from the CARE study versus the phase 3 studies, I looked at it and the phase 3 rilpivirine studies, less than 4% had rilpivirine mutations at baseline. They did see a failure rate of around 14-15% in those that did. As compared to the CARE study, 12% had baseline rilpivirine mutations, and they only had 2 virologic failures.
Just to say, part of the difference though between the studies, they're hard to compare because their viral load monitoring was so different.
Mhm.
So the more you monitor, the more kind of low level failure you can find.
Right.
Robert wants to put you on this. If we have time, we can go to Nettie's question, which is sort of unrelated. I don't know if you're looking at it, Lucas. That'll be a pharmacy question to you. But
Okay.
I think Robert's question is great. Sort of what's the takeaway here? What's your approach to
Yeah.
this?
Yeah. Yeah.
You're our guru. So
Yeah.
how are
No,
you
I,
doing?
I, I mean, I still think, baseline genotype for all is appropriate. Yes. Yes, I think there is definitely value in our proviral DNA resistance testing. I think in situations where people have unknown histories, long ART histories, you don't know what regimens they on, what responses they've had, or you don't have prior resistance testing and you suspect they had failed in the past. I think there's still a lot of value in doing proviral DNA resistance testing in certain situations. I think, as the data accumulates, from Africa about the efficacy of 2 nukes plus an INSTI or 2 nukes plus a PI, and even people with a bunch of TAMs and things like that, we have to continue to decide how we want to manage those situations in terms of what antiretrovirals we choose, and maybe that affects the need for resistance testing or not. But at this point, I think there's still, value in doing proviral DNA resistance testing in people in certain situations. And I think for evaluating rilpivirine, it's still worth doing, because again, our goal is for nobody to fail. And if we can prevent virologic failure in some people by doing proviral DNA resistance testing, whether that is the case or not, I don't think that question's answered, but I'd rather err on the side of caution.
Well, and maybe that answers the question for you that Nettie asked. About using archive to check for
Yeah, I
M184V.
can read it.
Yeah.
I'd like to ask about the routine use of archive to check for M184V prior to switching from Triamec to dolutegravir 3TC in long-term patients who do not have a baseline geno. I've heard there is no need to check geno prior to the switch, but this has come up for me a few times, and in one patient I checked archive and 184 was present, so I didn't switch. Yeah, Nettie, in someone that has an M184V, traditionally, we're not going to choose a Bacavir 3TC dolutegravir in that situation, but we've certainly seen several situations where people maintain suppression on that regimen with a 184. So I think to get to the point of the question, I don't think being suppressed on a Bacavir 3TC dolutegravir rules out the presence of having a 184. In the rare situations in clinical trials where people develop resistance on a second-gen INSTI, a 184 has shown up on people with abacavir 3TC dolutegravir. So if you suspect a 184 could be there or are unsure, we also are doing proviral DNA resistance testing before simplifying to dolutegravir 3TC. Not in everybody. I think if you have a good clinical history and you can, feel confident it's not there, it's fine just to simplify. But if we do suspect it's a possibility, we look for it, and then you could get to that whole other conversation about using dolutegravir 3TC with a 184, but that's a different,
Right. Yeah, I'm not going to go
different
into that, but
discussion. Yeah,
with the popularity of Triumec, a bunch of people sort of ended up on it, and then you have them, and you didn't start it, and you're like, "Can I put you on Dovato and save you a little bit of risk, whatever?" But
totally.
it's
Yeah,
a surprisingly common scenario.
it
Thanks.
is. Yeah.
And I see Shannon's hand, but it's after 9, so I think you'll have to do that separately. So sorry, Shannon. When we're in person, we can mingle, but it's a little hard to do this. Lucas, this was great, and it sounds like this is going to be a tradition because everyone's mandating it.
Yeah.
No, this is really very helpful and a great way to start off the new year thinking about resistance. So, thanks everyone, and we'll see you next week, which is in person. Marvin, am I right? Next week is Melanie Thompson,
Correct. Yeah.
Emery from Emory. So please, folks, come and join us. We love to make our visitors feel special, and there'll be food. So, have a good day, everybody. Thanks, Lucas.
Thanks.